due to start at 4:30. If you could just roll with us for just a few more minutes, because the presenter has gone missing. But I'm sure that he'll be found on his way very, very soon. If not, we will have a very interactive one-on-one session, okay? But thanks. And I was just noticing the gender numbers in this room, and it's very, very fascinating. Okay, and please, if we could make this as interactive, as provocative, as thought-provoking, whatever, okay? Let your hair down. Dennis Onyango, Advocacy Africa Foundation, who's a guru on migration. Do you English? Present.
care, how I was scared, unaware of my dreams. Just an heir to what my parents had seen, how unfair it all seems. Collar to throat was the barrio joke. Had 3 flowers, a comb, and some dollar store lokes. Iron and rags, keep your eye on the sack. A disguise for those admire, but never fired a mag. I grew tired of that, I grew eyes on my back. They drew iron when I drew rhymes, now who's firing back? Told myself, keep your mind on them raps, knowing damn well this shit's chess. Denzel in distress is for the damsel, lying on track 719, my spring training days. Clever with rhymes, I ain't explaining a thing, though I ain't claiming to bang. I say in criminal slang, I speak better with signs and subliminal hymnals. Lines look minimal until I paint a king. Be a Rodney or mine who can make the claim, when it's minds like Stevens who create the game. Be a Tut, Louis or Midas, the mistakes of James. These times got me relying on the king of kings, cause ain't a hand that can change a thing. Can you blame the ring? We'll paint a man with some angel wings, so keep it moving. My style's deep, see me confusing me in 20 in a league of our own. Where have you been? Where art thou? You who trend? Where is art now? Please let me clue you in. I said 20, thou league, see, I drop jewels and use the last 3 bars and parts to prelude. Dang, Sylvan said I see you, man. Brought my skills from LA to the EU land and farm altar. And on this altar I offer my language, so all words are Auburn, sorta like an autumn. See my loose leaf changing and my too deep say it and we'll all learn. I said language, altar, and Auburn. I'm saying pages are getting read as they all turn, but they on an altar. I'm saying they all burn, words are getting purged and the flames call us songs urns. If all of our songs earn and we get paid well, is it cause we all learn that only fame sells? If you're not at all concerned if we get paid well, you can take a name, just make sure that it's framed well and hang it high. Expose it to every angle. Guess it's all the same when they claim no one can tell. Maybe it's a way that our name spelled. Altar, a little lower than the angels.
Because the presenter has been held up, so I'm sure they will come in a minute. And if not, I will step in for the presenter. Welcome. My name is Gary Jones. I am the Senior Humanitarian and Security Advisor for UNAIDS, based in Geneva with a global portfolio. And it's my honor, my pleasure, to be with you today to moderate this session on improving health service provision for migrants and internally displaced persons. As we're sorting out the presenter's presentation, let me run you through which I believe are some of the core concepts that we need to keep in mind always when we talk about internally displaced people and when we talk about migrants. Noting, of course, that these are handy terms, but not very accurate. A migrant is not necessarily an internally displaced person, nor is a migrant necessarily vulnerable. So my first word of caution, please, is that when we use these terms, these are aggregate compounds that need to be disaggregated as best as we can. Disaggregated in terms of socio-economic profile, as well as age, of course, gender, in all its diversity, in disability, for example. We must always keep in mind that those characteristics will help determine the levels of vulnerability and what are the options available for resilience. I've got gadgets everywhere here. Can you hear me now? Could you hear me before? I'm sure there's a very good, oh yes, for the, okay, all right. My children call me a dinosaur when it comes to all this. I remember when the white chart was invented, we thought it blew everything away, but anyway, enough of that. I have a few introductory notes that I'd like to give with you, please. Now, the Resilience Fast Track Network is well placed to see how we can organize political will, community engagement, and equity-based approaches leading to better health for all. Again, these are very big terms, very big words. What do we mean by an equity-based approach? We often find when we talk the language of migration, we talk of generalities. Equity, this is good, it falls off the tongue easily. But how equal can we say is it for an illegal, irregular migrant, for example, who slipped across the border from Central America into the US, or is up from the Sahel and now living in Europe, or somebody from Syria who's now in Turkey? How equitable are their options? Can they simply just go into a health center and say, hi, I have no papers, I'm totally illegal, but we're having an equity-based approach, which means everyone is equal when it comes to healthcare? We heard this morning that in theory, the answer is yes, it is possible. But we must challenge ourselves to see how practical and how realistic are these expectations. Now, migrant health is extremely dynamic. It changes all the time. Forced migration depends invariably on outside forces. Climate change, violent conflict, gang violence, Haiti. Whatever it might be, it is constantly changing, which means we can come up with an equity-based, inequalities-based plan, and the next week it's irrelevant, or so many parts of it, because a different population has moved on, and they have different challenges. It's a different gender, it's a different age, it's a different dynamic all the time. So the first thing I would like to say in our deliberations, we really do need constant vigilance, constantly aware. I've been as guilty as anyone of going into, for example, an internally displaced person's camp, coming up with a great plan, and then by the time it gets funded, by the time it gets accepted, by the time you start to implement, and 6 or 7 months later, half of the camp is either halved or doubled, and their needs have changed. We need to find ways, and I need to find from you new ideas of how we can be responsive, not knee-jerk reactions, but how we can constantly respond. This morning we had an excellent presentation on community-led monitoring. Fantastic, and I'm all for that. That's where it's got to be, that's the future. But we've got to see how and in which ways that community-led monitoring can help to keep us up to speed all the time in these situations, which constantly change. Threats to migrant and IDP health change constantly, as I just said. We saw it with COVID-19. We're seeing it now with monkeypox. And we have always known it for HIV. And right now, WHO warns us of a spike in cholera. The world is now facing a massive cholera outbreak in different parts of the world. And note, and what do they put it down to? They put it down to war, violence, poverty, and of course, climate change. These are some of the external factors which is driving the cholera epidemic. But within those people suffering, facing likely infection from cholera, which remember does unfortunately still hold a high death toll, there will be people living with HIV, possibly already with compromised immune systems. We have to be vigilant all the time. These are the real-time questions that that demand our attention. Resources are invariably scarce. When have we ever been in that station when we've had too much money and we don't know what to do with it? What a wonderful problem that must be. But sadly, the situation is opposite. How are we going to find money, resources, people, locally, internationally, if necessary, to be able to help deal with the dynamic of migrant health? Because it comes and goes. And if I only have $100 left in my budget, how and where am I going to spend that $100 when I have to represent my case to my seniors, to my constituents, to the local MP? I have to think broadly. It comes a question so often across the board of resource mobilization, but it is absolutely at the key. And it's hard to raise funds when we say, actually, we don't really quite know how many, and we don't really know what their needs are, and we're not quite sure of but please give us your money. It's often a very difficult situation to be in. There are ways, and we're going to find out how to do that shortly. Now, we have the Global Compact on Migration, which has hardly been mentioned this morning, from 2018. It's obligatory by states, but the Global Compact on Migration, as indeed for refugees, it lays the foundation of much of our thinking of what to do. Why is that not first and foremost in our cities' debates? Because it's just as relevant for urban centres as it is for rural refugee camps. I would like to propose that one of the first things we have to do is to look at that compact and why is it already seen as something out there? How can we make it real? How can we make that as the basis as we write our project proposals, as we do our reports? How do we feed into international policy agendas? What's the message that we need to get across? Let's look at the case of Ukraine. Ukraine, as we heard today from our speaker, desperate situations at the moment, with the millions of people internally displaced, with the millions of people now across the borders. But I, for one, as many, are very, very proud to be part of an international community that can meet the challenge, that can provide. And I think, by and large, I take my hat off. I think it's marvelous what the Ukrainian authorities themselves, they have not far from giving up. They're taking the lead and showing us what needs to be done. And they're supported wonderfully by the international community. So, of course, why did we not see that in Syria? Why did we not see that in Juba? Why do we not see that in Cabo Delgado? Why, etc., etc.? Why do we make those differences? We can argue it's geopolitics. Some people even say there's more than a trace of racism here. Whatever the idea is, let's learn from that Ukraine example, because how wonderful the world would be for migrant health if we could have a Ukraine model replicated from the Rohingya crisis in Cox's Bazar right the way through to the Venezuelan outpouring. How wonderful that would be. So I say absolutely 10 out of 10 for Ukraine. Let's see now how we can make that the reality in every part of the world. How do we affect the international agenda? What do we as collectives need to do? Under international law, generally speaking, there is no assurance that people forced to flee across international borders will receive any assistance, let alone durable solutions to their displacement. This displacement creates not only health but also legal protection issues. We talk of migrant health, displaced people's health, but there's also within that group an exceptionally vulnerable group of people. And we need to raise their voice. This is stateless people. Sadly, in many parts of the world today, it's terrible patriarchal, hypo-macho lines when it comes to statehood. You have to follow the line of your father. If you don't have a father, sorry, you're no good. Oh, but I've always been living with my mother. My father ran off. Sorry, that doesn't count. We need your father. We saw this in Afghanistan, for example. We've seen it elsewhere in parts of the Middle East. So what of those people born in a refugee camp? We know that the length of stay in refugee camps, it's growing every year. Previously, 18 months. You can see by my age, I remember going back when I was dealing with refugee crises, IDP crises 20 years ago. It was about 18 months before the situation resolved, people returned. Now we're looking at a situation of up to 14 years. That is the difference now. Look at Kakuma, Dadaab in Kenya. These provide very excellent examples. So does Kigoma in Africa. This situation seems to perpetuate itself. But what are the stateless people? if you will, we talk of irregular migrants, but an irregular migrant, my work, they'll say, I'm from Côte d'Ivoire, I'm from Venezuela, wherever it might be, but they have a sense of themselves. That's so important, a sense of identity. But what happens if you say, well, I was born in a refugee camp, and I'm not, for example, I'm not Somali, I'm not South Sudanese, I'm not Kenyan, so basically my life is Kakuma camp. Can you imagine how you would feel if that was your identity and they talk of closing the camp down? Where are you going to go? Where are you going to find that help? These are the real situations, because when we talk of health, it's physical, it's mental, it's emotional, it's spiritual health. The multi-dimensions, the social determinants of health. And when it comes to migrants and IDPs, and within that, stateless persons, these are the factors we're up against. We need an advocacy. We need to hammer the desk hard. We need to raise our collective voices saying that the laws must change and that a child must be allowed to follow their mother's line. And if their mother has passed, for example, sadly, then they must be able then to have their caregivers, their primary caregivers' nationality. There must be a sense of identity. Okay. The rise in migration, which we'll see in just a minute, the rise in cross-border trafficking, it's the statelessness, it's the violence. Now that violence is carried out not just two warring tribes, two warring nations. It's not just that. It's not just a Russia versus Ukraine situation. What about domestic violence? We often see spikes in domestic violence in times of crises. Ukraine, sadly, had one of the highest rates of domestic violence in the world before the war. And with all this trauma and the horrors, can you imagine what it's like now? When we talk of we must deal with all forms of sexual and gender-based violence, let's start looking at our own household as we start to look at much higher national conglomerates, if you will. And when we talk of health, does everyone in that household have access to health? What are we doing as organizations, but what are we doing as individual human beings to facilitate, to create that enabling environment so that everyone can then access within our household, within our community, within our country? Because the discussion, the debate on migration talks of generalities. Good, nothing wrong with that. But as I said at the start, let's break it down so that we know that we are talking as well at a very individual level. HIV-related stigma, as we heard, it affects at all levels, and it's particularly so. Can you imagine? I have friends now who are migrants. Okay, that's a bit tricky. Look at the xenophobia, for example, in South Africa. You're coming over. So already you could be, many parts of South Africa are incredibly welcoming, by the way. That was just a recent news item. But what happens now if you come over? People see you're taking scarce resources. And wait a minute, I'm paid my tax for those resources. I want my kids to go. They need to be vaccinated, and you get told, sorry, that those vaccinations are now for the migrants. How are you going to feel? You're going to feel cheated. So, well, that's not very fair. But then, of course, international law is everyone has the right to health, which means those migrants do, in fact, have as much right to health as our children do, to use the example. So what do we need to do? Better resources, better planning, more inclusiveness. I think that's where the answer lies. We all know, for those of us who work in health, is that actually, if we're honest, we could do a lot better job in looking after our resources. We could kind of get a lot more efficient. WHO are normally the first to say that that's what we have to do. And being, as I say, HIV positive, irregular migrant status, living in another land. And now what happens if you're, for example, part of an LGBTQI+ community, which often, sadly, faces extreme levels of violence and discrimination. You can see where I'm going. It compounds, it builds, it compounds, it builds. So at the very end, you have someone who's actually next to impossible to get that health care. What are we going to do? I think we have to look at our communities, our networks. We can't just simply say, this is unfair, or woe is me, this is really bad. We need to get down on our knees and we need to start looking at our own location. What can we do as a togetherness to get over this? All right. With the increase in frequency and intensity of disasters associated with climate change, disease profiles change, as to the numbers will rise. Again, let's not forget the fact climate change, that big unknown factor. We plan. Community village. You go to Mozambique, you sit with the chief medical officer, and you say, okay, these are our disease profiles. So these are the medicines that we need to treat those illnesses, those conditions. And we need staff competent in dealing with malaria, for example. Whatever it might be. Malaria, you know, it's vectors born out of floodwaters, and Mozambique provides a very good example of that. But now we have climate change. Ironically, that flood might change to a drought now. Madagascar is a very good example. It's just simply flipped over owing to climate change, which means the whole disease profiling has now changed. But the way it works, the system works, is that you put in 5-year plans, so you've still got 4 years left to run on a flood situation, even though it's now a drought situation. In resource-constrained situations, how are we going to deal with that? We need to be much more innovative, much more responsive. We need to make sure that when we plan, there has a much higher degree of flexibility. With WHO, we're working to see how indeed we can make that. But this is an often missed thought, and sad to say, as I'm sure you'll all agree, kind of climate change is getting worse every year. It's now the norm. So what are the disease profiling, the epidemiology? What will it be 10 years from now? What are we going to be dealing with? Existing national, regional, and international regimes only respond only to some of our concerns arising from displacement. And yet we must deal with the entire spectrum. Those of us working with HIV, it's, what an uphill task. We sit with very good colleagues, and just to use that example again of Mozambique, where we were looking at an area with 18% prevalence amongst the adult population. And yet, in terms of the external emergency response, HIV was excluded. And when we said, what the heck is going on? And we were simply told, well, yeah, but you know, if we give the funds, the space on the airplane, to logistics, to carry your ARTs, your condoms, whatever it might be, that means that space is taken off to deal with typhoid, dysentery, malaria, cholera, yellow fever, etc., etc. And these are very real hard choices that we have to keep making in the humanitarian space. I would certainly propose that we need a whole new way of thinking. The likes of you, me, these venues outside, we need a whole new model where because the old, rather static model, I fear, is no longer relevant. And I would like to finish this part by simply saying while the voices, and I'm quoting here, while the voices of scientists, academics, politicians, and development practitioners always dominate the debate, us included, however, local knowledge, values, and beliefs from those impacted communities at the heart of the emergency are the essential elements of navigating the way forward for the future of health. And again, how crazy would it be if the next Fast Track Cities, or a similar event, is actually held in a refugee camp, in an IDP camp, if actually the organisers were those displaced people themselves? I'm sure many of us at different times have done this, but let's make it the way of working. Let's make that our agenda. At this stage, according to my notes, I would be handing over to the presenter. It's rather empty at the moment. I've been playing for time hoping that someone will come running through that door with a big apology. And are you here? I'm getting waved at by the presenter. You're there virtually.
Yes.
There's been a change of plan. Thank you. Thank you very much. We didn't come running through the door, but you onto the screen. That's just as good. Let me quickly introduce you. Your slides, courtesy of the back desk, have been put up. Ladies and gentlemen, distinguished guests, let me say, without further ado, to introduce our guest speaker, Dr. Nangzor Hutun Mint, and I've just destroyed your name, and I totally apologize for that. But Nang is the Senior Health Operations and Compliance Officer in the Migration Health Division of the International Organization for Migration, IOM. He supports IOM health assessment programs through planning, pre-migration health activities, clinical risk and quality management, incident management, and provision of technical advice to IOM regional and country officers. And Nang is a Myanmar national and a holder of a BA in medicine. He has many more things besides, but I will now at this juncture, Nang, say welcome. I'm looking for the camera. Welcome, and over to you if you would like to run through your deck. Thank you.
Thank you, Gary. Yeah, there was a bit of the miscommunication, but I'm happy that I can listen for a while from some of the talks from such a legend from you. And thank you, IAP. Hello, can you hear me? Hello. Can Gary confirm
Thanks, man.
that you can hear me?
Yes, go ahead.
Alrighty, thanks. So thanks for the introduction, Gary, and thanks to IAPC for inviting me to this conference, which is very timely. I am 9, as Gary has introduced, and I am a migrant. So what does migrant means? As Gary has stated, it's
If you can just to put into presentation mode, please. Can we put into presentation mode the PowerPoint?
Yeah, it is already in the presentation.
Probably is on your screen.
Oh, okay.
We don't want to miss a bit of your presentation. Do we do that here or over there? There.
Is it better?
Now, yes, spot on. Thank you.
Alrighty, thanks a lot. So I am a migrant, and what really migrant means? So migrant is, as Gary has explained, it's a very loosely umbrella term. It kind of mean any person who moves away from his or her place of usual residence, whether within a country or across the international border, temporarily or permanently for a variety of reasons. So if we put that definition to perspective, literally 1 in 7 person in this world are migrants. Of course, there are different categories of migrants. Gary has touched on a lot, and they are really differ in terms of vulnerability, if you ask me. And it is very timely that we can talk about this topic because half of the global's migrants live in the city, and more than half are women and girls, and a third are aged between 15 to 24. And the number of people displaced by the man-made or natural disaster is 82.4 million. And sadly, 20% of all the migrants are stay in the irregular situation. So these figures really underscore the different vulnerabilities that all the migrants are facing. And when we are talking about migration and health, we have to be cognizant that migration really is the social determinant to health. So if it is through well managed, migration can definitely have a positive impact in the developments. But in the meantime, when migration is in an irregular situation, it poses a lot of vulnerabilities to the migrants, especially for more marginalized populations such as women, girls, the elderly, the LGBTIQ community, and such. So when we are trying to trace migration and health in the 2030 Sustainable Development Goals, so 2030 sounds like a little bit farther away, 8 years from now, but really this decade is the decade for action. As Gary has explained, being and staying healthy is a fundamental human rights. I believe we have a very good discussion this morning with the panel. And it is not just a fundamental human rights, but it's also the essential precondition for migrants to work, be productive, and contribute to the development. And migrant workers really are the substantial contributor to the development. So uh, if we really want to achieve all these SDG goals by 2030, we really need to address the vulnerabilities of the migrants. Otherwise, it will be, like kind of like a shortcoming to achieve the objectives. Um, it is rather encouraging to see that all the stakeholders are right now kind of like getting more comfortable with talking the uncomfortable subjects such as migration and health because of its intersectionality in the questions of human rights, social protection, public health, international relations, security and policy and such. So what do we do as a kind of like international community? So as Gary has explained, there is a global compact for safe, orderly, and regular migration. So this global compact is something that IOM has championed, and it is really the first ever intergovernmentally negotiated UN agreement for the common approach to managing international migration. It has a lot of objectives, 23 objectives, that cover all the aspects of migration. So we said it's 360-degree approach. And it really is underpinned by a lot of guiding principles and that are roots in the Universal Declaration for Human Rights, SDG goals, and even the international laws. Even though it is non-binding in the principle, it really kind of like provides the common terminology for key migration issues and the blueprint for the comprehensive right-based, equity-based migration policy. Uh, One of the mainstream objective 15 is really to provide access to the basic services for the migrants. So that's what we really want to advocate to, the cities, because you really are at the kind of like a cross-cutting nature of implementing labor, but as well as you have a say in the policy making level as well. So our department, Migration Health Department in ION, what do? We are very active in three core areas. We like to call it security, resilience, and governance. So in the health security and human mobility pillar, we work on outbreak preparedness and response, pre-migration health activities, health-related travel assistance, and health services, even for the UN staff. So basically, this is the pillar that my regular day job is. Another pillar for the health resilience is that we provide primary care for people in crisis context. So we are active in some of the refugee camps that Gary has talked about, and combating the persistent diseases, HIV, TB, malaria, which we have a lot of good relationship with IAPAC and all other stakeholders. They are gender-specific health services because we streamline all our programs into the gender-sensitive programming, immunization services, MHPSS. In the governance, we are advocating for the policy for the universal health coverage, capacity building, and researches. So those are the areas that we are active in. And so as a snapshot in 2021, we walked through more than 1,000 of health staff across the world. And we have supported like more than 800 health facility, and out of them, 69 is actually run by our own IOM clinics. We also even kind of like go and develop in the migration health programs and with two teleradiology center that basically kind of like interpret the chest X-ray across the world. We have 53 laboratories with 9 biosafety laboratory labs that actually is helping a lot of the national tuberculosis program with the smear and culture methods. And there are many more activities for the vaccination, including COVID-19 vaccinations. And we are also part of the UN family, so we even supported more than 20,000 UN staff and their dependents, even within the time of COVID-19. So as this is my day job, I really would like to highlight the IOM's pre-migration health activities because it really is quite a key process and program for the well-managed migrations. It identifies health conditions of public health importance, both communicable and non-communicable. So it kind of like contribute to the IHR as well as the law of the land of the destination, transit, and the host countries. And it also kind of like support the migrant themselves by providing continuity care linkage between pre-departure, travel, transit, and post-arrival stages of migration. We emphasize on the fitness to travel so that no one and nothing really poses a danger during the migration phase. And also we provide preventive and curative care such as vaccinations, and these activities are really intended to minimize or mitigate public health and public safety risks related to the mobility. If you're looking on the right side of the presentation, you might probably notice the dots that a lot of our migration health assessment centers are right now in the global south. That helps people migrated to the more developed in nature. But our wish and hope is that if we can really streamline these kind of activities for a regular migration, that will benefit both migrants and the host community as well. The QR code is if you scan it, it will bring you to the link for our migration health assessment program in general, and please feel free to explore it further. So even during the COVID-19, we have more than one way to support the migrants for the COVID-19. And one of the key roles that we actively playing is in the point of entry. So one thing that COVID-19 really hit hard is it really stopped the global migrations. So we are trying to, kind of like resume the migration by advocating for the need to resume the migration, as well as equipping and helping the stakeholders to how to ideally manage the situation as well. One of the recent development is that we have kind of like do a little bit of survey between the plan versus the practice. So, with all the advocacy work, with all the good intentions that we do, there are a lot of good progress and inroads to the inclusion of migrants and health. So this study really provides us into the insight into what actually is possible at the policy level and what's going on the ground. So this is basically the data collected through various sources, mainly from the national deployment and vaccination plans, as well as we kind of like collect the information through the official communications, government websites, and then etc. In the meantime, we also kind of like collect the information through the community-based programs so that they can validate whether the actual plan of the eligibility for the vaccinations are actually available to the migrants. So if you look at and compare these two graphs, it is quite encouraging that even though the numbers of the country that have the policy of including different types of migrants in their national vaccination plan. In practice, actually, slightly more countries are actually providing the vaccine to the migrants. So basically, it's a good thing. However, if we looking down to the different categories of the migrants, 90% of the migrants in regular situation have access to COVID-19. Not 100%, but it is quite a good percentage. But the story is different for migrants in the irregular situation. Only 57% are, having an access to the COVID-19 vaccine. And probably the internally displaced people are in the most vulnerable situation, with only 46% having the access to the COVID-19 vaccine. Around 70% of refugee and asylum seekers have reported that they have access to the COVID-19 vaccines in the practices. So basically, one thing that we really have to underscore is that even though when we talk about migrants, they are like they can be different kind of migrants with different vulnerabilities. So when we are making a policy, we just have to make sure that it reaches to the most vulnerable and the marginalized population. So we kind of like collected those information through some months from March to June of this year. So basically there's slow progress if we compare the data between March and June, and there's a slightly better pickup rate in terms of who have the access to the COVID-19 vaccination. So even though it is not the ideal situation, it's going in a good direction. And if you can, what we would like to advocate for is to really promote the targeted deployment strategies to make sure that no migrants left behind, and also to improve the efficiency and the provision of the operational support at the ground level, which I believe cities are best positioned for this. So all things said and done, what can we really do? What can we do is to make sure that health is mainstreamed into the larger migration policy, as well as to mainstream migration into the health policy as well. So those are the three kind of like global agendas that IOM has been very active in. IOM has been very active in the International Migration Review Forum, which is a platform for all the member states to monitor the progress of on the implementation of the Global Compact for Migration. And as IOM is the one of the organizations under the UN umbrella, so we do the secretariat for the UN Networks for Migration. Linking to that is the Global Health Agenda. We are very much working together with the WHO and all other stakeholders in the initiative for Health for All and the IHR and the UAC initiative as well. So all of those efforts are to contribute, as I have stated earlier, to the SDG goals, making sure that all the objectives in each goal is met, and it will not be met without we really mainstream the migration and health to the development agenda. So with that said, I would like to end my presentation here, and thank you so much. And if you have more questions, you can write to me or my department here. And I have provided more links and QR codes so that you can view on the internet for the better information. So with that said, thank you so much. And I believe we may probably have a few more minutes for the question.
Ladies and gentlemen, the crowd is milling outside. There'll soon be a riot. So we have to go a little bit quickly because we're a few minutes over. Thank you, Nang. He's gone. Okay, thank you very much for that. If you can hear me, Nang, thank you. I just have a few very quick closing remarks and then we must clear this. Where do we go? So what do we do? Let me isolate a few things. We need to realize the growing inequalities and vulnerabilities exacerbated what we are now calling the Triple C. Who knows what the Triple C is? Well, you're going to learn it. The Triple C is COVID-19, climate, and conflict. The Triple C, COVID-19, climate, and conflict. Those are with us today. They are increasing our vulnerability. Let's see what we can do together to try and address that. If we had more time, I would go into greater details. Cities and local governments, of course, have a role to play. We are having an influx in migrants everywhere. Did you see the latest news from the mayor's office in New York complaining that their health services are collapsing with the influx of migrants coming into the city? If New York can't cope, what about everywhere else? Just look at it like that. Let's work now with the Triple C. Let's see what we can do. And I'm just very quickly going to finish with, we need practical insights. We need to know how to shift to a life-centered approach. We need to find innovative finance models involving public-private partnerships that can generate revenue for health services while ensuring equitable benefits. We need to develop insurance solutions. Can you ever think? Insurance for stateless people, insurance for displaced people or migrants? It actually can happen. We need to promote comprehensive, integrated, practical approaches providing health for all. And my last point, we need to engage the youth. Most migrants are young, very vulnerable. Many are not protected by primary caregivers. Many are on their own. Have you ever realized how many unwanted pregnancies exist amongst young women on the move? It's a horrific number. You know that most migrants going into Europe from Africa are HIV negative. After 2 years in Europe, most are HIV positive. That shows you the level of vulnerability that they face within our cities here, right here, in Spain, in Switzerland, in London, across the board. It's got to change. These are young people. We need to make sure that our services are accessible for them. And we need to, of course, to find the flexible funding that responds to the urgency of the moment, not now, not 20 years, now, and recognize the non-traditional benefits of working with youth, such as connections to the community and the impact it has on local cultures. I thank you all very much for your participation. We're right out of time. If you like to, I'd be more than happy to discuss this over coffee. But right now we have to exit this room. But I thank you again very much for your time. Thank you.
Thank you very much.
Fight off 1,000 monsters hiding in the sands on Mars. Hijack a flying saucer, steady on the hand. Fly home, sweet home, where the saucers go to get all cleaned up and put away. Call it a day. Back home, sweet home, where the heroes go to get all cleaned up. Anyway, let's call it a day.
downs, baby. Sometimes we were tight, and sometimes oceans apart. Gotta learn just how to move on without you. Move on without you. We had our on and offs, baby. Sometimes we were tight, and sometimes everything but. Gotta learn just how to forget about you. Forget about you. When you call me up and sound so sweet, there's nothing to blame. But when you don't pick up for days on end, I see my mistake. I'm out of patience. Come out and say it, that it's over now, so I can stop chasing. We had our good and bad, baby. Sometimes we were smooth and sometimes out of control. Gotta learn just how to be fine without you. Be fine without you. When you call me up and sound so sweet, there's nothing to blame. But when you don't pick up for days on end, I see my mistake. I'm out of patience. Come out and say it, that it's over now, so I can stop chasing. We had our ups and downs, baby. Sometimes we were tight, and sometimes oceans apart. Gotta learn just how to move on without you. Move on without you.